Today, we have our very own faculty member, the Casey Overby Taylor, to present. Dr. Casey Overby Taylor is an associate professor, a recent associate professor, I might add, of medicine in the Division of General Internal Medicine and Biomedical Engineering and the School of Medicine. And she's a core faculty member in the Institute for Computational Medicine. She has an affiliation with our Biomedical Informatics and Data Science section, and joint appointments in the Department of Health Policy Management in the School of Public Health and in the Computer Science Department as well. So clearly, as a good informatician involved in many areas of the university. Her research draws from biomedical informatics and the related fields of biomedical data science to address the challenge of how to incorporate digital health technologies into clinical research and clinical practices, particularly for genomics. She also draws from comparative effectiveness research approaches, including experience with conceptualizing and measuring implementation outcomes, to study the use of clinical decision support as a strategy to improve the adoption of clinically actionable guidance. She was honored as a previous recipient of a Johns Hopkins Malone Center for Engineering and Healthcare Fellowship and a current recipient of the Microsoft Digital Investigator Fellowship and the NHGRI Genomic Innovator Award. Dr. Overby Taylor, take it away.
Thank you, Dr. Lehman, for the introduction. In this presentation, I'm going to give an overview of some of my ongoing research to uncover patient profiles to inform how we design technologies. And I'd like to start by telling you a bit about my view of the world from a research perspective so that you have a better understanding of how I frame research and what problems I find particularly useful and important and challenging. You've heard some of my background, but just to talk a little bit about my training, it's been in biomedical informatics and public health genetics with pre-doc and post-doc training prior to starting my first faculty position at University of Maryland in personalized and genomic medicine. After that, I joined Hopkins in 2016, so it's been about 6 years, with most recently having a joint primary appointment within medicine and biomedical engineering. And as part of this, I've been growing my research program to focus on how we bring together data science methods and design research to develop more effective ways to engage patients and deliver recommendations to clinical providers. And a chunk of my research is around delivering care for genomic-related care. However, today I'm going to talk about another clinical space that we've been pursuing a bit more. And so the learning objective is to understand the relevance of uncovering patient profiles to target engagement in healthcare delivery strategies. And I'm going to describe two existing projects or ongoing that on some ongoing work around how we're using data science strategies to uncover patient profiles for these two different scenarios. And so just to set the stage, I like to show this figure because it just shows the diversity of data that's out there. And these data sources are just becoming more and more accessible, and finding ways for us to leverage those data sets and bring them together to be able to come up with useful insights related to patients and clinical providers is an ongoing challenge and something that we're beginning to see more of. So this figure just shows that in the blue, we have EHR data, which covers several types of data, including medications, demographics, encounters, diagnoses, so on. And it's in structured and unstructured format. There's also other resources, direct-to-consumer genetic testing, for example. There's social history from sources like police records, and there's also wearable devices that are in social realms such as Twitter and Facebook, where you can draw insights on patients that could be relevant for clinical use. And once we get past the challenge of being able to bring all of these diverse data sources together, we'll want to use them in a useful way for clinical care. Once there's a level of evidence that makes it relevant. And so we're starting to see more examples of where research and practice are coexisting to leverage those data and to learn from them in an ongoing way to improve healthcare delivery, which is particularly relevant for precision medicine because the evidence base for precision medicine is constantly evolving. And so there needs to be a strategy to keep up to date to the most relevant information in order to provide the best care for patients over time. So just to give a bit of background of some of the research thrusts that I'm tackling, the problems that I'm seeking to answer are around the value of evidence from research, moving from research to patients and providers. And so that's around actionability of knowledge, understanding the technical characteristics of evidence and resources, as I mentioned, um, the 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 evolution of evidence. You may change status from being actionable to non-actionable or non-actionable to actionable, and being able to keep track of these technical characteristics of the knowledge base that's maintaining these evidence resources. Also, there's technical characteristics of the research and healthcare delivery frameworks. And we'll want to leverage, for example, our EHR capabilities in how we deliver new technologies. And so being aware of those characteristics, the limitations and the evolving capabilities is important as we're wanting to bring new technologies into use. And finally, understanding characteristics of researchers, healthcare providers, and patients is something that I'm going to focus on in particular here, along the lines of discovering the patient profiles that can help inform how we design technical solutions. And there's several strategies that I use in my research where I'm focusing again on these data-driven approaches to discover these patient profiles. So, in what follows, I'm going to talk about one particular challenge around how we deliver what we learn in an effective way, and in two problem areas. The first problem area is that we have patients that have variable healthcare delivery preferences, and so how we implement a technology, a strategy should take these delivery preferences into consideration if we want to optimize adoption of those strategies. In the second example, I'm going to describe how we use a modeling strategy to that we want to translate into clinical use and minimize the impact of perceived reliability and trustworthiness of models, which is a common challenge when implementing risk prediction. And so we're wanting to support the trust through more interpretability, for example. And so I'll go into how we went about doing this. So general strategy, designing for adoption with patient profiles. And again, this first example is addressing the problem of having variable preferences for healthcare delivery. And we've used cluster analyses of preferences to identify profiles for research updates, for example. And this strategy could potentially be used in other domains, but this is our initial focus. And so to provide some motivation, opportunities for patients to be updated on research activities can encourage high participation in research. Also, patients that participate in research have variable preferences when and how they want to be updated. And this is a finding from a study that we did to understand willingness to donate samples to biobank research. And we just found that a good portion of people who said that they weren't willing to participate initially would change their willingness with opportunities to be updated regularly. So it shows that this is something that could potentially lead to more participation in research. And then what I'm going to go into more detail on is our work to identify preference profiles that could be used to define tailored contact plans. And I'll go into more detail of what's meant by that. So our strategy to identify preference profiles, we wanted to assess the hypothesis that there would be distinct preference profiles among surveyed individuals using hierarchical cluster analysis. Uh, and this was based on 4 specific research update preferences around content, content type, timing, mechanism, and frequency of updates. We did this with a population of existing study participants in genomic research at two institutions, and we used cluster dendrogram diagram to show the clustering relationships between the data. And this, our aim was to characterize these preference profiles by making comparisons between the clusters to see what features were distinct between them and which were similar. So we recruited from 2 institutions. Our survey, we administered a survey to 397 people altogether. And overall, the majority wanted general research updates, which was not surprising. And when we surveyed them about different content types, timings, mechanisms, and different times of year when they would want to be updated, there were several that we found there was high levels of endorsement, and so we just defined that as more than 50% of the survey respondents indicated a preference for these updates. And so 3 of 7 updates regarding content, 4 of 7 major milestones, 2 of 5 different mechanisms, and 1 of 3 different times of year were highly endorsed. And I'll go through those in a bit more detail. But first, we also identified 4 distinct clusters using hierarchical clustering. And these groups were defined according to their preference, their preference for, or their being driven by high value, high engagement, low value, or level of value, level of engagement. The way we defined value was according to certain preference dimensions. For example, media coverage was one of the preference that we asked about. And so if they had a preference for media coverage, that's something that would bump them up as high value. Or if they had a preference for knowing when there's a publication, for example. The preferences that we looked at to understand engagement were around things like number of frequency of contact that the patients would want throughout the year, and also different types of engagement strategies. I think we had one of our options was to be able to be connected with others in a social forum, to be to connect with others. And so we had that as a higher engagement. And so within these groups, we found the largest group was moderate value driven, low engagement driven. But they were pretty spread between these, between all of these. So you see there's 83 in the high value driven, high engagement driven, 69 in the low value, low engagement, and 75 in the moderate value, moderate engagement driven. And a lot of this work was, and I mentioned that Natalie Flax-Manov was the postdoc and conducting a lot of the cluster analysis research. And so just to go into a bit more detail about the specific preferences that we saw within these dimensions. First, looking at the content update dimension, we see for all of the clustering groups, the top preference was to have brief descriptions of major findings. And then we see the second or third for across all of these was description of purpose and goals of the research. Education materials was also a desire for 3 out of 4 of the groups. And then brief descriptions of media coverage was one of the higher preferred types of content for the high value, high engagement group in particular. And then when looking at timing of updates, we also see several of the similar types of updates across the groups. So we see number one for two of the groups is being updated when findings are reviewed by other researchers and clinicians. Also, that's number three for one of the groups. Another one that we see across three groups is when findings are published in an article. And actually, when research is completed, was found across in the top three across all four. Looking at mechanisms for updates, there were only three options here, or actually, no, there are four options here. But so we see for the top choice for updates, which was a little bit of a surprise. The top mechanism for updates was email, where we internally felt that text message might have been higher across the board. But we had email and electronic newsletter by email as the top two for all of these. And then the third was a newsletter by mail for three of the groups and text message for one of the groups as the third option. And then when looking at the frequency updates, see for this one, there were only three options. So you just see different ordering for the first, second, and third ranked choices. Quarterly was the preference for three of the groups. Once a month was the top preference for one of the groups. And once a year or less was the second preference for two of the groups. And once a month or more was the third preference for two of the groups. And overall, when we wanted to see if there were factors that were distinguishing among the four clusters, we found that one of these the question around opinions about using clinical information for research, one of the questions on that topic was we saw different proportions indicating a preference. And in particular, we asked if they would be comfortable with allocating less money to research to be able to support these kinds of updates. And so you can see that for one group, it's 30% indicated a preference, and it's a lower for another preference, and so we see a significant p-value among these for this question. There weren't significant differences according to different characteristics such as gender, age, and education, and all of them all of the participants had an interest in research focus, so that wasn't really a distinguishing factor either. So in summary, for this project, we found that most participants want results from studies in which they participate. A one-size-fits-all approach may not be sufficient to address participant desires, and this study adds some in-depth exploration of specific preferences of research participants for the different types of content modalities to provide updates, timing to receive the updates, and frequency to receive updates. And our focus was on general research results versus return of results that would be clinically relevant. So this is keeping it at the being aware of of your research results and things like contributions to science and so on. We also identified these distinct preference profiles. And so that suggests that there is some variability, but just looking across the board, there was quite a bit of consistency in the top three among the three groups, which suggests that we might use these findings to specify the high priority features if we were to develop a strategy to implement services around to actually provide these kinds of updates. And also future studies beyond this realm may benefit from exploring preference profiles as a strategy to do something similar in specifying what are the priority features to implement. And then finally, this study provides evidence of a need for funders to incentivize researchers to communicate results to participants. to participants, because there were groups that didn't want you to reallocate funds that are from research to go towards supporting these kinds of services. And so there needs to be some kind of incentive for research to do this, because it can one lead to potentially a broader range of people who might be willing to participate in research, and two, would improve engagement in research. So now I'll transition to a second project where we aim to approximate complex patient profiles up front in a multivariable model risk prediction. And so the problem that we wanted to address with this strategy is this issue of clinicians not trusting or believing that multivariable predictive models are reliable. And the rationale for using models to assess clinical risks is that we want to do this when there are many factors that contribute to the risk, and individual risk factors alone have poor predictive value. There are challenges to adopt multivariable models like what I just described. And so this work addressed the challenges by first engaging clinical collaborators early. And this, as I'll show you, can minimize uncertainty in the long run. And then second, using a clinical phenotyping tool to approximate patient profiles. And by doing this, it both minimizes the complexity and improves interpretability. Case study that we focused on for our study has been around recurrent preterm birth. Preterm birth is defined as babies born alive 37 weeks of pregnancy, and it's the most common cause of death in children under 5 years old. And there are several long-term complications due to preterm birth. And one of the main motivating factors is that the patients have a complex phenotype, and it's comprised of many risk factors. So there's a need potentially for multivariable modeling. And this figure just shows several of the risk factors that could be relevant. And this shows our overall strategy. This is work that was largely led by Ilya Radsev. And I'll go through the different aspects of our strategy that motivate this use of profiles. So first, as I mentioned, we used early engagement with clinical collaborators, which helped us to refine the goal to predict recurrent preterm birth. And in particular, early in the discussions, we found that there are many risk factors that are different for different delivery subtypes. And so that led to the design choice to create models for these two subtypes in addition to a naive model. And then we also wanted to ensure that there's actually something that could be done once a prediction is made. And so we clarified what kinds of strategies were available to prevent preterm birth. And so the two unique delivery subtypes that we explored was spontaneous and indicated. Where spontaneous is, where indicated is one that we actually had fewer patients, and it's often an induced delivery by cesarean section. But I'll give some more details about our study population to clarify this. Our data source came from the Genomic and Proteomic Network for Preterm Birth Research longitudinal cohort, which had 446 women with a history of spontaneous preterm birth, and they were followed throughout their pregnancy. And this was something that's made available to request by NHCID. And so this just shows their study design for data collection, which involved initial screening, enrollment, and cohort assessment, followed by an enrollment visit. And they had a first return visit, a second return visit, the hospital admission for preterm labor, and term labor and delivery. And all of these things were captured across the study population. And so we did a retrospective cohort study with these data. A key method in using this data was around building this clinical phenotyping tool. And the goal for applying this is reducing the dimensionality of the data. We first started with previously published phenotypes, with one being dropped because it defined the preterm premature rupture of membranes is something that's excluded because it actually was part of the definition for spontaneous preterm birth. And we also extended the phenotype definitions to include additional risk factors. An important aspect of the modeling is that we incorporated levels of evidence of whether or not somebody had a particular clinical phenotype. And those levels were none, possible, moderate, and or strong. And this figure here shows, we already went through the step one, which was drawing from an existing data set. Step two was the feature extraction from that data set. And then the third step was the phenotype mapping of those features into these different clinical phenotypes. And so this included infection and inflammation, decidual hemorrhage, cervical insufficiency, uterine distension, placental dysfunction, maternal comorbidities, family history, and maternal stress. And then the final step was incorporating these clinical phenotypes in addition to other features such as sociodemographic factors and obstetric history into the statistical modeling strategy. The ultimate risk factors that were included in the model were 23 factors, 11 sociodemographic characteristics, 7 of the clinical phenotypes, and 5 characteristics related to previous obstetric history. And we performed a survival analysis with the outcome of time to delivery. We performed univariate analysis, which I won't go through given our focus on multivariable analysis. And our multivariable analysis uses traditional statistical approaches, Cox proportional hazards regression model. And we report hazard ratios for delivering before 37 weeks of gestation calculated for each of our covariates. And for model assessment, we looked at concordance index, AIC, and log rank test. And so ideally, we want to have higher concordance index and lower AIC score. To give a little bit of detail about our sample, this was a group of 428 women that qualified for the analysis. The gestational age of delivery ranged from 23 to 41 weeks. 32% delivered preterm, and 72% had spontaneous delivery, and 28% were indicated for delivery. And so this is a group of patients that had a prior preterm birth, and so their risk for a recurrent preterm birth was higher than average. Also, the age range from 17 to 47. It was primarily white, but there was also a large group of Black patients. Around 32% were Black, and the majority were non-Hispanic, so 74% non-Hispanic. Also, about half came from low-income background, and the majority were living with a partner, were unemployed, possessed public insurance, and had a high school degree or higher. So the focus of this prior study was to have individuals that were from a diverse socioeconomic background. The clinical profile characteristics are summarized here. So about half had some evidence for infection, 31% had strong evidence for family history. The majority had not undergone a C-section in previous pregnancies, and they had no evidence of decidual hemorrhage, cervical insufficiency, placental dysfunction, maternal comorbidities, or maternal stress. So these were, these are some of the phenotypes that we were assessing in particular, and they hadn't, majority didn't have prior evidence of those. And on average, the participants had 2 previous deliveries and slightly over 3 years since their last pregnancy. And this is just to show some model performance where we see that models for total and spontaneous subtype are highly significant. One concern for the indicated model was that there was a small sample size. As I mentioned previously, there were only 25 patients that fit within that category. And so we had a relatively high p-value. And so, yeah, there may be overfitting, which led to this higher concordance. And looking at the Cox regression analysis, we see that among these sociodemographic factors, there were some significant differences between groups. So we see that there is, for the unknown household income, there was higher risk compared to the lower household income reference. And that's in the spontaneous group. In the indicated group, there were 5 factors that showed lower significance when compared to the reference. And then in the total group, similarly, this unknown household income showed a higher risk. So this is probably one of the more interesting findings here, since these are measures that you can, this is leveraging our clinical phenotyping tool, and was able to, for patients that were predicted to have spontaneous preterm birth, patients that had some evidence of decidual hemorrhage and that had cervical insufficiency were at higher risk. And for the indicated group, patients that had moderate evidence of placental dysfunction had higher risk, and the risk for total was similar to spontaneous. And then looking at the obstetric history for spontaneous, previous birth rate, actually for all 3 models, previous birth weight, there were significant, that was a significant risk factor. And then for indicated, there was number of previous deliveries, number of abortions, and having a previous cesarean section that were led to higher risk. So overall, this work developed a framework that uses a clinical phenotyping tool for multivariable model to detect at-risk patients. By doing this, we're approximating complex patient profiles, and it reduces the complexity and improves interpretability. So just looking at those, the factors that increase risk, you're able to clearly understand what's contributing to risk. And Cox regression model is well suited to analyze patients who may be lost to follow-up, which can happen in the real world practice of patient care. And the models that we built may be useful for early detection of patients at risk for recurrent preterm birth. There is more work that needs to be done to assess these models in practice. The subtype specific models in particular may be useful at a time of routine prenatal visits, and be able to be used to estimate risk for delivering preterm. The potential There's a potential for the high-risk score produced by the spontaneous model to help physicians choose an appropriate intervention that may mitigate the risk. And then there's the potential for the high-risk score produced by the indicated model to apply proper preventive measures. And so the suggestion was to produce both models for a patient because you don't know what their risk for either outcome is at the time of a prenatal visit. However, future work, of course, would have to assess the generalizability of these models in EHR data sets is our goal. So lessons learned from both of these projects. Hopefully, I have convinced you that uncovering these kinds of profiles can be useful to target patient engagement and healthcare delivery strategies. For the first project that was described, cluster analysis was used to identify patient profiles for research updates. The findings confirmed a need for more tailored communication strategies and provided evidence of a need for funders to incentivize researchers to communicate results to participants. And this kind of strategy could lead to more data-driven technology design. The second project that we covered shows that approximating complex patient profiles and multivariable risk prediction may help to optimize potential future adoption of that model. The two strategies we used were engaging clinical collaborators early to minimize uncertainty, and the minimizing uncertainty is on the implementation side. So once you make this model available, if we were to just provide a total model rather than the two delivery types, then there would be more uncertainty around what action to make. We also engaged our clinical collaborator in feature selection and interpretation of the findings. Again, one of the main contributions was our strategy to use a clinical phenotyping tool to approximate these patient profiles. And doing this really minimized the complexity greatly and can improve interpretability by understanding what features were important for predicting risk in the multivariable model. So I'd like to acknowledge lab members that contributed greatly to these two projects. So Dr. Flax-Manav and Mr. Radsev. Also my eMERGE collaborators, and I've just named the Hopkins collaborators that participated in the survey study that we described. So Dr. Matthews, Dr. Shute, Dr. Ford, and Dr. Lehman. Also, the phenotyping tool project collaborators include Dr. Jellin and Dr. Bai. And the funding for this work was supported by eMERGE subcontract from Geisinger, as well as my Microsoft Investigator Fellowship. And some of the work we're doing now builds on this and is coming from my Genomic Innovator work. So with that, I will wrap up my talk and can take questions.
Just want to thank you for a nice broad view. I know you've been really committed to getting patients engaged in the research process, and it's great to see how this has come out. So let's see, Dr. O'Neill says, with the advent of genetic services like 23andMe, are patients bringing their DNA results into clinical visits? Can they expect anything now or in the future that is tailored to these results?
There was a time where I was attending case conferences, genetic counseling case conferences, and I remember there being discussions of patients who would bring their 23andMe results, saying, you know, I'm at high risk for breast cancer or some condition like that, and the reaction is always, well, we have to do the testing again anyway. So I think that this is something that is emerging, these direct-to-consumer genetic testing companies. However, there are some commercial companies that can provide clinically CLIA certified testing. And so that is something that's maybe treated a bit different than a 23andMe that's doing genotyping results. So I do think that they 23andMe in particular, and some of the other direct-to-consumer testing companies spend a lot of effort on defining or building their knowledge base for helping people to understand their results. So I think that is tailored because the content that they provide to their consumers are tailored to their specific results, and I think they do a decent job at describing those in a way that's understandable, using health literacy and genetic health literacy, and showing table and how they describe numbers and things like that. So definitely seeing that.
We've also seen that somebody bringing their genetic results is a huge signal of engagement and wanting to participate. And do
Mhm.
you have any evidence of that? That people who bring their genetics are approach shared decision making in a different way from those who don't?
So I think that's a very good question. I'm not sure. I guess we need to do that study. But I do think it's a different pop. I think it's it's a high. I do think it is an engaged group that's going out and getting their own genetic test results. Whether it improves shared decision making is something that I'd have to just look into further. But I could see it. I could see it potentially leading to more healthcare utilization, and and so there could be benefits and drawbacks to it. So I think there's it's an area to look into further.
Like a great background for your grant submission. Uh, Dr. Ray is asking about that first project, that it's compelling and refreshingly participant-centered. Could you comment on your experiences working in this dimension, including rewarding aspects and any barriers that should be addressed to enable you and others to extend this work?
This survey study went longer than expected, and part of the reason for that, so I was doing this study as part of the emerge network, which is many institutions that have biobanks, and I've enrolled their patients to participate in genomic research. And so I proposed this study, and there were many institutions that said they were interested, but it was additional work beyond what they were funded to do to be able to actually participate in the project. And then in parallel, there was a goal to understand preferences for the return of results, the return of clinically actionable results. And so that took a preference over this question when we're not providing care. This is a very I mean, I see why. I understand it's about the priorities of the program to be able to execute it. I think we were lucky that were able to we were able to do this at Hopkins, and we were able to do it at Columbia. So those are the two groups that were able to identify. One, it's identifying a patient group that's separate from their main patient population. I think that was the big thing, because they were already serving the group, their main patient population, a lot on other topics that they were required to study. So it was a big ask to say, can you also identify another patient population to respond to this? So that was the biggest challenge, I think, was doing that. But I do think we were able to do this study fairly quickly at Hopkins, and but it was targeting a population that had my chart and was enrolled in in a genomic research study already, and patients that had, so these are people who are potentially already pretty engaged in research, and so it's not and also technically savvy. And so their preferences may be a little bit different than a general population. And so um, to be truly participant centered, we need to include all potential participants. So that's an area that I think would be good to extend the work further. And I do think it's a good start though to design tools for tailored communication as a next step as well.
Just building on that, have you been involved with, PCORI asks for the dissemination plan that we don't know what to do with. Have you consulted with any projects on helping them craft that part of their proposal?
So no, I haven't actually. I wasn't aware of the requirements for PCORI. So
If anybody has any experience with that, maybe you can uh, share that in the chat or the Q&A, because it seems it may be that things have evolved since you started the study, since it did take a while. Dr. Stevenson asked about you mentioned the biobank a few minutes ago. You asked whether the patient preferences worked on the context of the Hopkins biobank, the All of Us study, or some other biobank. What was that?
So that was in the context. So that was when I was at University of Maryland. They were planning to build a biobank, and so that was where the motivating research came from. These willingness to participate in research was around um, planning for a new biobank there. For Hopkins patients, what we did was identify anybody that had a DB-GAP protocol, and as a surrogate for identifying patients that have participated in genomic research. And then we took a random sample of people who were on a protocol that required that DB-GAP submission, and that's who we sent recruitment emails to complete the survey to. So that's how we did that here.
Did Maryland see the results of the survey? Did it help them to inform their biobank policies? Or?
I think so. I have to go back and see. I actually don't know if they may have made the decision not to build a biobank. The data goes into a IRB protocol to get approval, but whether it actually gets implemented is another thing.
Sure. Dr. M asked about the second study, whether you ended up developing a score for the risk of preterm birth for easy interpretation by clinicians.
So we didn't take it to that. We didn't take it to that step, and so that would be another future area. And that's a good question. Yeah, so that would be next step. We did have, it's a relatively small data set, which is why we went more to, traditional statistical strategy. You can maybe more like more of a machine learning strategy might be able to generate a score. So we'd have to just think about what would be needed to do that. But ultimately, you know, we think that there is interpretability from understanding the features, but in what's delivered and shown is something that more work needs to be done in getting
Yeah.
a design for what shows to clinicians.
Tell me if I understand what you've shown correctly. We often talk about scores, but that doesn't tell you how to talk to the patients with that score. I think what you're saying is that a profile tells you who you're talking to, and who you're talking to is not just a score. It's not just a probability. And
Yes.
I think that's a very profound point, uh, to recognize the type of person you're talking to, not just the score that you're talking to.
Right, because the type of person you're talking to may help you to figure out what action to take. Just knowing, like, if you're above some threshold, says uh, this person's at risk, I should do something. But knowing like what profile characteristics are important and will help to know what to do. That's the goal, the hope.
uh, some people do Bayesian analysis and decision analysis and focus on the threshold. So they appreciate hearing this, the need to not just focus on that number. So I appreciate that. There was another
People
question,
like you, yes.
and that's why I take it very much to heart. I appreciate that. Dr. Ferrer says, do you envision patient-generated data as a part of data ingestion for AI or augmented intelligence systems?
So again, like we used a simple, we used a traditional statistical strategy here. When we're talking about data ingestion for AI, I think I I get stuck on the mechanisms to like so the first slide was we have all these data coming from these different data sources, and how do we bring them together? So we use this study data set, which is very, I would say, is very complete potentially when compared to real world EHR data. And so a lot of work needs to be done to see how well this strategy generalizes, given there's going to be a lot more messiness, a lot more incomplete data. And once we can get if the performance works well in this real world setting, and then we think about uh, how we can scale this strategy for more of these like AI types of systems.
It's funny, you were talking about trust in the first study. I would imagine that clinicians need to figure out how to trust the patient-generated data. Um,
Yes,
I
yeah.
hadn't thought of that before. Do you know
So
it? Go ahead.
I was just gonna say, so I've done like my going back, I guess, dissertation research was looking at like confidence in clinical decisions based upon the types of knowledge that's provided. And one of the things that builds trust is having the stamp of approval from some organization. So I'm kind of wondering if there's going to be, an organization has has a vetting process where if you see that seal, then maybe that is something that it's a trusted recommendation or something like that. Also, the information, like we were talking about, what information you provide, you I mean I guess it's a different issue, but if there are specific recommendations, provide it with some type of confidence around that recommendation. I think that also builds some trust, because we know that there's always going to be some uncertainty, and if it's not communicated, then that may lead to less trust in what you're seeing as well.
Yeah, at the same time, sometimes when you communicate uncertainty, everybody stops listening to you. Um, and people want to hear certainty. But people of a certain age may remember the Good Housekeeping Seal of Approval. Um, and then we've had HAN code for web health data. So the notion of a seal of approval is an interesting patient-generated health data seal of approval, not from Apple, Amazon, or Google, I think is what people want. Dr. Ray follows up with, is there good evidence that investigators should trust? Yeah, patient collected. So this speaks to the same trust. Do we know anything about trusting patient collected data more than, quote, conventional data? I wonder if there's any data like, we always say patient claims. I hate that verb that we put in the history, right? Patient states, patient claims. But if we had the data coming from a gizmo, do we trust it more than the patient's history, as an example? We don't know that yet, do we?
Good question. So you're saying like data that's observed and entered by a clinician versus data that that a patient enters themselves
Right,
or
or
provides themselves.
what a patient reports versus what's right. You have different scenarios. You have a patient reports, the patient records, and the gizmo records. And one would imagine that there would be different trust. The Good Housekeeping Seal of Approval would probably apply to the third, where the gizmo records. but in the first two,
Right.
I don't know.
Right. The patient records it, all. I guess all of these have some level of like some different types of biases associated with it. Um,
Right, and your point, we want to trust the patient, right? Isn't that your whole point? Is that we want to trust the patient, we want to support the patient, um, and yet there is a reality. Sometimes it works both ways, and I think we're navigating that with open notes, with my chart, and all of that.
mhm.
Um, before I do have one more question, but does anybody else have a question from the community before we wrap up? Um, I don't know if this is an easy question to answer, but the in general, when you go looking for subgroups in your data analysis, you get criticized that you're looking for subgroups, and here you're consciously looking for subgroups. So can you help clarify that distinction between the fishing expedition on the one hand and the type of purposeful searching that you're doing on the other hand?
We're specifying what characteristics we're looking for um, to distinguish patient groups in this case. Um, so for example, that we didn't include demographics in our clustering, but we looked at the end if there were differences in our clusters. Did our clusters vary by demographics? So I don't know if it's modifiable or like actionable variables that we want to be able to search for clusters, and that's the strategy we've been using versus the things that, including the things that we can't change. Um, it's important to look at things like race to see, if these strategies would impact one group differently than another group. But I wouldn't do that at the initial step. And I don't know if that's what the question was getting to with issues with subgroup
No, no,
analysis.
that I think is that I wanted you to expand on what you mean by a subgroup, and that's helpful distinction. The things that and we know that a lot of data-driven approaches, when given race and given some other factors, come to the wrong conclusions, and so it's important to be mindful of how you're dealing with that.
Mhm.
Well, great. Give, given that there are no more questions, I want to thank you and thank everybody here, and hope to see you all back next month. We're talking about global health informatics. So thank you, Dr. Overby Taylor, and thank you everybody for joining. Bye bye.
Thank you for having me.
You're welcome.